Good morning, ladies and gentlemen. It's a pleasure to have the opportunity to speak to you this morning about this new technology, TULSA. I'm going to first give a very brief overview of where I think the place of TULSA is and why I'm excited about it. There is a spectrum of disease aggressivity with prostate cancer, from extremely indolent lesions that really don't require any treatment at all and are managed with surveillance, to very aggressive diseases that warrant similarly aggressive therapies, surgery, and radiation. And as you move on the spectrum from conservative management to aggressive management, the impact on quality of life increases. So there is a major unmet need for an intermediate type of therapy for those patients who have more than completely indolent disease but don't have aggressive disease. And that is where the minimally invasive technologies and the partial gland ablation approaches have so much promise. Traditionally, there's been a very large gray zone for the management options for prostate cancer, with the exception of a very few patients diagnosed after a TURP with low-grade cancer. One had the option of treating patients with surgery, radiation, heat, freezing, electrocution, you name it. No one would really criticize. So there's a very large gray zone until recently. This is now changing, and I'll come back to that. The current management of localized prostate cancer has changed quite dramatically, and in particular, there has been the adoption of conservative management for grade group 1 or Gleason 6. And this is based on some key facts. First of all, that grade group 1 or Gleason 3 has molecular genetics that resemble normal cells in the majority of cases, and the impact of this on the clinical outcome is that these patients never metastasize. In contrast, as soon as there are elements of Gleason 4 pattern present, the cancer has some metastatic potential. It may be low, but it's not zero. And so the stakes become higher. This table lists the well-known pathways of oncogenesis, also referred to as the hallmarks of cancer. And it's truly remarkable how the difference between Gleason 3 or grade group 1 and Gleason 4 and higher profoundly disaggregate cells between those that have essentially normal genetics on every one of these pathways and those that have altered genetics with overexpression of oncogenes, deletion of tumor suppressor genes, amplification of important genes, and so on. These two grades of cancer are like night and day, not only in terms of their molecular genetics, but also in terms of their behavior. The implications of this difference is that Gleason 3 is a non-metastasizing cancer. Gleason 4 definitely has metastatic potential. And this is reflected in the large active surveillance series, including ours, where the likelihood of prostate cancer mortality in patients managed conservatively is somewhere between 4 and 5 times higher between those who are diagnosed on biopsy between Gleason 3+3 or grade group 1 and higher grade groups. So this has very profound implications for clinical management. So to my mind, this gray zone has shrunk dramatically, and in a sense, there's a new gray zone. Whereas before, patients who had more than a few microfoci of low-grade cancer could be managed in one of many, many ways. Now I think this has been disaggregated so that the large group of patients with low-grade cancer, grade group 1, should be managed conservatively. This is no longer in the gray zone, even if they have fairly substantial volume of disease. On the other extreme, the patients who have multifocal high-grade cancer warrant aggressive therapy with surgery or radiation or a combination of both. But this leaves a large group of patients, about a third of newly diagnosed patients, in the middle, where one is uncomfortable with conservative management, and yet the big guns of surgery and radiation probably represent overtreatment. And that is where I think TULSA belongs. And these are patients with intermediate risk cancer, grade group 2 to 3, or Gleason 7, or occasionally small volume Gleason 8, with unilateral or index cancers. And this constitutes about a third of newly diagnosed patients. Now, just to move on to some of the data that you've seen earlier today, and I just want to emphasize a couple of key points. The first point is the evidence we have to date, and it is early days still, but the evidence for efficacy of this therapy is quite compelling. The PSA reduction data is really extraordinary, that the median nadir of PSA after treatment was 0.3, which represented about a 95% reduction. This treatment really ablates tissue, and the dramatic PSA response suggests that the extent of tissue ablation is really very substantial. In other words, essentially all of the targeted tissue certainly no longer secretes PSA, and this implies tissue ablation. The second point is the biopsy data, and just to emphasize again, although persistent disease was identified in a proportion of the patients on repeat biopsy, this is quite a small proportion of the total cohort. And I think it's fair to say that the persistence of microfocal Gleason 6 does not undermine the effectiveness of the therapy. So I'm really impressed that roughly 80% of patients treated with TULSA had no evidence of clinically significant cancer after therapy. And then the functional outcome is where you really see the value of this. So this data that shows incontinence, less than 1% of patients at 1 year are requiring more than a pad per day. Obstructive symptoms tend to be quite minimal and return to baseline by around 3 months after therapy. This again is really dramatically different than one would expect with surgery and even with other types of focal therapy. And erectile function, and really the data shows that recovery to baseline by around 6 to 12 months in the majority of patients. Again, this is not surprising considering that the ability to target the tissue is so precise, but it's certainly very reassuring. And the adverse effect rate was low, and this also is consistent with what I've seen in the patients treated with TULSA, that there's really been very few adverse events, and those that have occurred have been relatively mild and easily manageable. And this data really confirms the safety of this approach. This was an early experience, and of course, one is on the learning curve, and I think the evidence that calcifications in the prostate may have undermined the effectiveness is one of the learnings from this data. 14 patients had intraprostatic calcifications and had a, relatively speaking, higher positive biopsy rate, and this will be something to take into account going forward. Finally, just to compare the outcome of this preliminary TULSA data to what is known about the outcome of surgery, radiation, and HIFU, the rates of erectile dysfunction consistently higher, the rate of incontinence, certainly with surgery, very significantly higher, the rate of stricture higher, both with prostatectomy and with HIFU, particularly whole gland HIFU, and of course GI toxicity, relatively common with radiation and not seen with TULSA. So from the perspective of the functional outcome, it looks extremely promising by comparison. My conclusions, therefore, are that this promising technology represents the next generation of energy-based image-targeted therapies. The data showed very favorable outcome in terms of quality of life and side effects. The persistent disease rate of 15 to 20% is consistent with other therapies for intermediate risk prostate cancer and quite encouraging. And I think this will also improve as patient selection is better understood going forward. And further, there is tremendous interest in using this for partial gland ablation in addition to whole gland, which was the focus of the TAC trial, as well as for the treatment of BPH. Thank you very much.